Hello everybody, welcome to our series of webinars concerning caring for people with early breast cancer. Let's quickly introduce ourselves. I'm Teresa Wiseman. I'm a Professor of Cancer Care at the Royal Marsden NHS Trust in London, UK, and I'm a member of the EONS Education Working Group. Meryl?
Hello everybody, my name is Meryl van Klinken. I'm from the Netherlands and I work as a palliative care nurse and cancer nurse in a Dutch cancer center. I am also part of the EONS Advocacy Working Group and I am an executive board member.
Hello everyone, I'm Celia Díaz de los Ríos. I'm from Spain. I'm an oncology advanced practitioner. I'm also working as a research assistant and I'm the co-chair of the Education Working Group.
Hello everyone, I'm Mandy Shoebridge and I'm a specialist breast cancer nurse based in London. I've previously been a nurse consultant in breast cancer at a big London hospital and I now work for Breast Cancer Now as a breast cancer charity.
So following on from our symposium from EONS 15, the recording of which is on the EONS website, we have been sponsored to develop a mini-series of 3 webinars as educational support for nurses caring for people with early breast cancer. If you haven't seen the symposium, do visit the site as it will give you an insight to people's experience of having early breast cancer and how nurses can help. The aim of this mini-series is to give an overview of the knowledge and skills needed to care for people with early breast cancer. So in order to do that, we're going to cover the following topics. Webinar 1, which is today, we're going to look at early breast cancer as a disease. We're going to look at pathophysiology, risk factors, genetic breast cancer. We're going to consider MDT work, European guidelines, and decision-making. And then we're going to do an overview of early breast cancer surgery. In webinar 2, on the 5th of December, we're going to do an overview of adjuvant therapies, including neoadjuvant therapies, assessment and management of treatment side effects and symptoms, and we're going to look at emergency situations and how to manage them. And then webinar 3, on the 19th of December, we'll look at the impact of early breast cancer on people and their families. We'll look at living well during and after treatment, management of common symptoms, educating patients about signs and symptoms of recurrence, and end of treatment summaries. So let's look at what we're covering in this webinar. In part 1, Mandy's going to look at the early breast cancer statistics. What are the risk factors and genetics? How do patients present? How are they diagnosed? And an overview of the different types of early breast cancer. Once that's finished, we're going to have a break for about 10 minutes. And then we'll look at part 2, which is much more about the European guidelines, recommendations for multidisciplinary team working and nursing roles, an overview of treatment and treatment guidelines. We're also going to cover surgery in part 2. So I'll hand over to Mandy.
So let's start by thinking about why we are focusing on a series of webinars on early breast cancer. Breast cancer is the most common cancer affecting women in Europe. It's important to remember that although it's rare, it can also occur in men. There are approximately 576,300 new cases of breast cancer in Europe each year, and male breast cancer accounts for about 1% of this. It's also important to remember that 90 to 95% of people who are diagnosed with early breast cancer are treated with intent to cure them from the disease, which is quite different from other tumour types. Having said that, 5 to 10% of people are diagnosed with advanced breast cancer at their first presentation, so they have treatable but not curable disease. Approximately 30% of people who are diagnosed with early breast cancer, even after full treatment, will go on to develop advanced breast cancer in the future, although for some that will be many years later. This webinar is focusing on early breast cancer only. But if you'd like to know more about advanced breast cancer, there is also an advanced breast cancer webinar on the EONS YouTube website. So if you search in YouTube for EONS ABC webinar, you'll find it. EONS have also developed an ABC for Nurses online education programme, which has been piloted from next month. So if you'd like to register, please go to the EONS website. So incidence is rising, but why is this happening? It's not possible to say what causes breast cancer in an individual unless that person is known to have a genetic mutation, but there are a number of factors that are known to increase risk. Some we cannot change. Being a woman is the biggest risk for developing breast cancer, followed by age. 80% of breast cancer occurs in women over the age of 50, as the incidence of breast cancer increases as we get older. There is thought to be a small increased risk for those who start their periods early and reach the menopause at a later age. There is increasing interest in breast density seen on mammogram, with higher breast density being associated with an increased risk of breast cancer. Research has shown that lifestyle factors are important. Studies have consistently shown an increased risk of breast cancer with increasing alcohol intake. The risk of breast cancer increases in those who are overweight after the menopause, but decreases in those who take regular exercise. Pregnancy has a really complex effect on breast cancer risk. Women are at slightly short-term increased risk of pregnancy due to hormonal activity. But overall, in the longer term, pregnancy reduces the risk of breast cancer. And breastfeeding also slightly decreases the risk of developing breast cancer in the future. Taking the combined contraceptive pill slightly increases the risk of breast cancer. However, this risk disappears within a few years of stopping it. Hormone replacement therapy increases the risk of breast cancer, and that risk continues for a few years after you stop taking it. As we've already seen, breast cancer is quite common, and therefore having somebody in the family with breast cancer does not necessarily mean that a person is at increased risk themselves. For most people, having a relative with breast cancer does not increase their risk. A small number of people will have a genetic mutation that does increase their risk of developing breast cancer, and we'll talk about this more later in the webinar. Finally, it's important to remember that most benign breast conditions do not increase the risk of breast cancer. However, atypical hyperplasia, an unusual increase in the number, shape or pattern of the cells lining the ducts or lobules, and lobular neoplasia, which is a change in the number, appearance and behaviour of the cells in the lobules, are associated with a slightly increased breast cancer. So let's move on and look at incidence in more detail. The incidence of breast cancer varies between countries across Europe. In recent global and European studies, the highest incidence was seen in Belgium, Cyprus and the Netherlands, with the lowest being seen in Bulgaria, Lithuania and Slovakia. So incidence is rising, but so are survival rates. The Eurocare 5 study reported more than 80% overall 5-year survival after diagnosis of early breast cancer. This figure continued to rise during the study, and it's important to remember that individual predicted survival rates will differ according to presentation and response to treatment. And for some groups, this figure will be as high as 95%. So these figures are really encouraging. So let's have a look at why survival is improving. In most countries, there's a trend towards earlier diagnosis due to increased awareness of signs and symptoms of breast cancer. Access to breast screening programs aids early diagnosis, but provision of screening varies across Europe. There are barriers to talking about breast health and attending for screening within some cultures, and work to understand and overcome these are really important. There are differences and inequality in the provision, funding and quality of cancer care across the countries in Europe. Differences in waiting times and access to optimal treatments account for about 1/3 of the differences we see in cancer survival. National cancer plans and the European Beating Cancer Plan that promote clinical guidelines, MDT working, and appropriate education, training and quality control measures have been shown to improve outcomes. Access to improved clinical pathways and advancements in treatment have also led to improved survival rates. So breasts are formed from glandular tissue that are made up of ducts, lobules, and fatty tissue. The lobules, which produce milk in lactating women, drain to ducts, which lead to the nipple. Breast tissue sits in front of the pectoralis chest wall muscles, which overlie the rib cage. So let's think about how we actually define early breast cancer. Early breast cancer is confined to the breast tissue or the local lymph nodes, for example, under the arm and axilla, or the intermammary lymph nodes chain in the center of the chest. This diagram also shows lymphatic drainage to the supraclavicular fossa in this area of the neck. But if cancer was found in that area, it would be considered to be locally advanced disease. So let's move on now and think about ways in which breast cancer is diagnosed. And we're going to start by thinking about breast screening. Screening is carried out on the asymptomatic population with the aim of early diagnosis. Uptake and provision of screening varies between countries, and cultural barriers and health beliefs can prevent people from attending. The ESMO guidelines state that regular, annual, or every 2-year mammograms are recommended in women aged 50 to 69. It may also be reasonable to screen women aged 40 to 49 and 70 to 74, although the guidelines say that the evidence is less strong in these age groups. Access to screening and screening protocols vary across Europe. Women with a strong family history, with or without a BRCA mutation or other mutations, may be recommended to start enhanced screening protocols with annual breast MRI and mammogram. Again, implementation of these recommendations varies between countries. So breast cancer can present in many ways. Some breast changes are quite subtle, while others are very obvious. People should present to the doctor if they notice any of the following: a lump or swelling in the breast or the axilla, a change in the size or shape of the breast. They may notice a dimpling or puckering of the breast, changes to the skin or redness or edema. Sometimes this is known as peau d'orange because it has the appearance of orange skin. You may also notice nipple inversion, nipple rashes or crusting, or nipple discharge. There's a wide range of benign changes that can present with all of these same symptoms, and therefore it's essential that people with breast symptoms are reviewed and assessed by clinicians with expertise in this area. There are some rare types of breast cancer, and we're going to look at a couple of them. So we'll start by looking at inflammatory breast cancer, which is the picture on the left. And this accounts for 1 to 5% of all breast cancers diagnosed. It's a rare and aggressive disease in which cancer cells block the lymph vessels in the skin of the breast. This type of breast cancer is called inflammatory because the breast looks swollen, red, and inflamed. Symptoms often come on quickly over weeks. It can be difficult to diagnose as the signs and symptoms can be similar to mastitis or a breast abscess, which normally would be treated with antibiotics. These cancers are always at least stage 3 at diagnosis and are not suitable for surgery as their first treatment. And on the right, we have a picture of Paget's disease of the nipple, which occurs in less than 5% of breast cancer diagnosis. It presents as a red scaly rash on the nipple, the protruding part of the nipple itself, which can be mistaken for nipple eczema, which is much more common. In some cases, the rash will extend to the areola, so the darkened skin around the nipple. The nipple can feel itchy or be inverted. Most people with Paget's will have an early form of breast cancer called ductal carcinoma in situ, which is also known as DCIS, but some will have invasive disease. We'll talk more about different types of breast cancer shortly. It's important to acknowledge that some people will present with more advanced disease, and these pictures are not very nice to look at. The picture on the left shows a woman with locally advanced breast cancer, and you can see flattening of the nipple and redness of the skin and skin infiltration. This disease would not be operable, and the patient would receive chemotherapy as their first treatment. The picture on the right shows a large fungating breast wound. Thankfully, presentations like this have become less common due to better breast awareness and reduction in the stigma relating to a breast cancer diagnosis in most cultures and communities. Again, this kind kind of disease would not be easily resectable and would be treated with systemic anti-cancer therapy, and in some cases radiotherapy. Malignant wounds can be very difficult to manage, and they're certainly very distressing for patients. People with breast symptoms should be assessed in specialist breast clinics, and we'll talk a little bit more about that in webinar 2. But a clear history should be taken, including when symptoms were first noted, previous breast problems or breast imaging, past medical history, medications, allergies, reproductive history. So when did your period start? Have you had any pregnancies? How old were you when you had children? Did you breastfeed? Menopausal status and family history. People will then have a clinical assessment. Anyone over the age of 40 should have a mammogram, and those with a palpable abnormality should have an ultrasound as well. Those under 40 will have breast ultrasound as their first investigation if required, because of the use of mammograms in the under 40 age group is challenging due to breast density. A biopsy of any breast abnormality noted on clinical examination or seen on breast imaging should be undertaken to give a histological confirmation of diagnosis. If palpable nodes are felt or nodes are seen to be enlarged or abnormal on imaging, then a biopsy should be taken of the nodes as well, as this helps with appropriate treatment planning. This overall process is called triple assessment, so a clinical examination, some form of imaging, and a biopsy if required. So let's review the ESMO clinical practice guidelines for diagnostic workup for early breast cancer. We've covered some of these diagnostic elements in our previous slide. But when breast cancer has been confirmed, there's some other diagnostic tests to consider. Further assessment of the person's general health would include a full blood count and bloods to assess liver, bone, and renal function. Some patients who are likely to require some of the targeted treatment, for example, trastuzumab or anthracycline chemotherapy, will need cardiac assessment as well. And in some people, further assessment of the extent of the cancer of the breast may be required, and this is usually in the form of a breast MRI. Other tests are not usually recommended unless the person presents with symptoms that are suggestive of advanced breast cancer or metastatic disease, or they have a high burden of disease, for example, lots of nodes in their axilla. So how do we stage breast cancer? Many of you will be familiar with the TNM staging system. In simple terms, the T refers to the size of the tumour. N indicates whether there's any nodal involvement or not, and the extent of nodes involved. So in the case of early breast cancer, this would relate to the number of axillary or intermammary nodes involved. And M indicates the presence of metastases or advanced breast cancer. So therefore, all early breast cancers would be M0. In breast cancer, it's common to use the stage 1 to 4 system to assess disease. Stages 1 and 2 are considered to be early breast cancers. Stage 1 indicates disease that's confined to the breast with no lymph node involvement. Stage 2 represents tumours that are bigger than 2 centimetres in size, and anyone that has lymph nodes involved in the axilla. Stage 3 is used to describe locally advanced disease, where the tumour may be involved in the skin or superficial chest wall structures, and may also be affecting the regional lymph nodes, for example, in the supraclavicular fossa, so back here in the neck. And stage 4 refers to people with metastatic or advanced breast cancer. So we're going to move on now and look at some of the different pathology types in more detail. Ductal carcinoma in situ, or DCIS, is a non-invasive form of breast cancer. This means that breast cancer cells are confined to the ducts and do not have the ability to spread through the duct walls or into the surrounding tissues or to other parts of the body. DCIS can often be seen as small dots of calcium, known as microcalcifications, on mammograms. It can sometimes be very extensive, meaning that mastectomy would be the recommended treatment choice. An untreated DCIS can develop into invasive disease in some people, but it won't do this in others. Most people are diagnosed with invasive breast cancer. Invasive disease can arrive from either the ducts or the lobules of the breast, and the most common types are invasive ductal carcinoma and invasive lobular carcinoma. All invasive cancers have the potential to spread to other areas of the body, but this does not mean that they will. All treatments given for early breast cancer aim to reduce the risk of this happening. So about 30% of people diagnosed with invasive breast cancer will go on to develop advanced breast cancer in the future. So let's look at how we grade breast cancer. Invasive breast cancer cells can be graded 1, 2, or 3, depending on how different they are from normal breast cells, how quickly they are growing, and their potential to spread. Grading is one of the factors considered when making treatment recommendations. Grade 1 or low-grade breast cancer cells look only slightly abnormal, very much like normal breast cells. The cancer is usually slow growing and less likely to spread than higher grade breast cancer. Grade 2 cancer cells look less like normal breast cells and are growing faster. And grade 3, the higher grade breast cancer cells, look fairly or very abnormal and are usually growing quickly. Before we look at the different subtypes of early breast cancer, it's important to learn more about human epidermal growth factor receptor 2, or HER2, and the hormones estrogen and progesterone, and their roles in breast cancer. Tumours can be tested in the laboratory using a technique called immunohistochemistry to see whether the cells display certain receptor sites or proteins on the cell surface. Some types of breast cancers are affected by estrogen and progesterone. The breast cancer cells have receptors that attach to estrogen and progesterone, and this helps them grow. About 2 out of 3 women with breast cancer will have cells that contain receptors for estrogen or progesterone. HER2 is a tyrosine kinase protein, which sends signals in cells regulating how a healthy breast cell divides, grows, repairs, and dies. It's normal for women to have a level of HER2 protein on the surface of the cells in her breasts. If someone with breast cancer has a normal amount of HER2 protein, their cancer is HER2 negative. However, HER2 overexpression or excess protein leads to the cells growing uncontrollably and creates an environment where abnormal cells can easily cause a tumour. As growth is uncontrolled, cancer develops rapidly, and there is a high incidence of recurrence in this group of cancers. About 20 to 30% of breast cancers have more than normal HER2 protein on the surface of their cells. So we've looked at the hormone and the HER2 receptors, and we'll move on to see how these influence the different breast cancer subtype definitions. In luminal A and luminal B subtypes, the tumour thrives on estrogen and progesterone. Blood levels of these tumours are often increased and changeable in premenopausal, perimenopausal, and postmenopausal women. The incidence of luminal A and B tumours is higher, typically higher in older women. Luminal A tumours are the most common molecular type and tend to grow at a slower rate of growth than other cancer types. They are defined by their hormone receptors, specifically estrogen receptor, sometimes known as ER positive, and/or, you don't have to have both, progesterone receptor, which is also sometimes referred to as PR positive. Luminal A cancers are also HER2 negative. Luminal B cancer is considered to be a more aggressive subtype of breast cancer, as the cancer cells tend to grow quicker than the luminal A subtype. They are positive for hormone receptors and possess a higher than normal amount of HER2 receptors, so they're both HER2 positive and hormone receptor positive. As we said previously, some breast cancers have a higher than normal level of HER2 protein on the surface of the cells, which stimulates them to grow, and they are called HER2 positive cancers. Triple negative breast cancer is a cancer that does not have any estrogen receptors, progesterone receptors, or excess HER2 protein. These results mean the growth of the cancer is not fueled by the hormones estrogen, progesterone, or by the HER2 protein. So triple negative breast cancer does not respond to hormonal therapy or treatments that target HER2 protein receptors. Basal type cancers are like triple negative breast cancers, as the cells are usually ER, PR, and HER2 negative, but they are two distinct breast cancer subtypes. Basal type breast cancer cells have changes in their proteins that triple negative cancers do not have. Histological molecular characteristics affect treatment decisions. In the last 15 years, there's been an emphasis on biologically directed therapies and treatment reduction to minimize adverse effects of treatment. And we'll explain more about treatment options in our second webinar. Most people will have somebody in the family that has breast cancer, but for most people that does not increase their own risk of developing breast cancer in the future. A small percentage of people, about 1 in 400 or 0.25% of the population, carry a mutated breast cancer gene. These are called BRCA1 or BRCA2 genes. When a BRCA gene is mutated, it may no longer be effective at repairing broken DNA and helping to prevent breast cancer developing. Because of this, people with a BRCA gene mutation are more likely to develop breast cancer and ovarian cancer, and are more likely to develop cancer at a younger age. The carrier of the mutated gene has a 50% chance of passing that gene mutation down to his or her offspring, as the child may actually inherit that particular gene from their other unaffected parent. Between 5 and 10% of women with breast cancer are thought to carry an altered gene. So let's look at the BRCA1 gene in a bit more detail. This gene is found on chromosome 17, which helps to repair DNA. It brings a 60 to 90% lifetime risk of developing breast cancer. The mutation is more common in the Eastern European Ashkenazi Jewish population. There is a higher incidence of triple negative breast cancer in BRCA1 mutation carriers. They also have a 40% lifetime risk of developing a second breast cancer. And women with a BRCA1 mutation have a 40 to 60% risk of developing ovarian cancer. Men with a BRCA1 mutation have a 2% risk of developing breast cancer and a 20 to 30% risk of getting prostate cancer. And BRCA1 mutation carriers have a 5 to 10% risk of developing pancreatic cancer. So let's look at BRCA2. They are slightly different. The BRCA2 gene is found on chromosome 13, which also repairs DNA. It means a 45 to 80% lifetime risk of developing breast cancer. Again, the mutation is more common in the Eastern European Ashkenazi Jewish population. BRCA2 carriers also have a 25% lifetime risk of developing a second breast cancer. Women with a BRCA2 mutation have a 10 to 30% risk of developing ovarian cancer, and men with a BRCA2 mutation have a 7% risk of developing breast cancer and a 30 to 60% risk of developing prostate cancer. Again, BRCA2 mutation carriers have a 5 to 10% risk of developing pancreatic cancer. So we're learning about new genetic mutations all the time, and there's lots of new ones coming along that we're learning about, but there are 3 other main genes known to increase the risk of breast cancer. Checkpoint kinase 2, or CHEK2, is found on chromosome 22 and helps to control how cells divide. It creates a 15 to 40% increased risk of breast cancer in women, but at the moment, the risk in men is unknown. The partner and localizer of BRCA2, or PALB2, is also found on chromosome 16. When no mutation is present, it works with BRCA2 to repair DNA. A PALB2 mutation causes a 40 to 60% risk of developing breast cancer. And Lau-Fumani syndrome causes a mutation in tumor suppressor protein 53, also known as TP53, and is found on chromosome 17. TP53 helps to repair damaged DNA. The TP53 mutation causes up to an 85% risk of developing breast cancer in women. So why is it important to know about these mutations and how do they affect treatments? So for women who are diagnosed with breast cancer, if they found that they are a BRCA mutation or a genetic mutation carrier, they may decide to have bilateral mastectomy as their treatment for breast cancer rather than unilateral breast conserving surgery, because they want to reduce the risk of developing a second breast cancer in the future. There's a group of drugs called PARP inhibitors. They're a type of targeted biological therapy that inhibit the enzyme poly-ADP ribose polymase. And these are known to be active against advanced breast cancers and that are known to be caused by BRCA mutations. And so if we know that someone with advanced breast cancer is a BRCA mutation carrier, it opens an option of using the PARP inhibitor drugs. And early work is also underway exploring the use of PARP inhibitors in early breast cancer, and it's likely we'll see advances in this field in the coming years. It's also important for people who are carrying the genes to know about the genes before they develop cancer. So people at increased risk of breast cancer may be enrolled in enhanced breast screening programs, and breast MRI may be used in this group of women in addition to mammography. Protocols for this will vary across Europe. Some women who do not have a breast cancer diagnosis may decide to have risk-reducing surgery to remove their breasts and/or their ovaries. Risk-reducing mastectomy decreases the risk of developing breast cancer by about 90%, but it's not possible to remove every piece of breast tissue and every breast cell, and so there still remains a very small risk of developing breast cancer in the future. And interest continues in looking at the efficacy of blocking estrogen for people who are increased risk of breast cancer with a drug like tamoxifen, and seeing if we can prevent breast cancer developing in this high-risk group of women. So in this first part of today's webinar, we've looked at breast cancer statistics and risk factors. We've looked at the diverse ways in which breast cancer can present and how it is diagnosed. We've talked about the importance of understanding staging, grading, and other pathological features of breast cancer. And finally, we've looked at inherited breast cancer and genetic mutations. In part 2, we're going to start by looking at the European guidelines for the provision of breast cancer services. We'll discuss the importance of multidisciplinary team working and nursing roles within the team. We'll then move on to give a broad overview of breast cancer treatments and the guidance that underpins decision making. We'll look at the impact of a breast cancer diagnosis and factors that may affect how people cope. And finally, we'll look at the role of surgery in the treatment of early breast cancer. In our next webinar, we will really concentrate on specific adjuvant therapies in much more detail. So join us again after the break.